The patient has come in. You've conducted your diagnosis and tests. The results have come back to you. What next?
Okay, so when the result comes back to me, it's important for me to be able to tell for this couple in front of me what exactly is the problem. So I can tell from the results. When I tell what the problem is, okay, this is the problem, what are the potential solutions?
So you look at the problem holistically, I assume?
Yes, please.
Because you explained earlier that the causative factors are not necessarily biological.
Exactly.
It could be social, it could be economic, it could be psychological,
exactly.
It could be genetic,
yeah,
based on your earlier postulation.
Yes.
So at the stage of analyzing the test, all of these things will be brought in.
Exactly.
All right.
So from the first consult with the patient, I know what are the potential stressors for this patient? What are the potential, where does this person work? Okay? Is it exposed to a lot of biochemicals, refineries? Because exposure on oil rigs, all those exposures also have the potential to affect fertility. So I have an idea of the social things the patient is exposed to socially.
Yeah.
Alcohol use, hard drug use, multiple sexual partners, infections, all of those things I have it in the
Radiation,
all of those things, yes.
food, substance, stimulants.
Exactly.
I mean, all of this.
Body weight. So all of those things, I have it. And then on the premise of that, I can counsel. For some people, we say, look, madam, I'm sorry, we can't do this now. You have to lose 10% of your body weight. Okay, you have to stop smoking for at least 6 weeks before we do this. You have to cut down alcohol by about 40% before we do this. Okay, if they don't cut it down, the result will be there when they come back to do the tests.
Because you have to conduct another test.
Exactly. Yeah, so we know what the issues are, we know what the problems are, and then we can say, okay, we think these are the potential solutions. If you take this one, it gives us a chance of 20%. If you take this one, it takes about 60%. If you take this one, it takes about 5%. Okay, I'm giving all this because you see, the fact that a doctor has recommended it does not mean it's acceptable. Coming back to the culture. Okay, so what is acceptable to me?
Mindset.
Exactly, what is acceptable to me? Okay, the 60% optional chance of pregnancy is not acceptable to me. I like the pregnancy rate, but the process I don't like it. Or the process I can't afford it. What can I afford?
So after you finished giving your prescription, in terms of maybe it's counseling or in terms of maybe further treatment,
yes,
or maybe you're now bringing them into the technology of artificial conception.
Right.
What next?
Okay. Well, so for the people that are counseling, usually we'll have feedback after 6 to 8 weeks to see how they're doing.
Weeks.
Yes. But for people that need the fertility treatments, usually we will spell out timelines for them.
Okay.
This is how we start. This is how we start. This is how we start. So we have 4 stages. Okay. So stage 1 is when we get the gametes together, the sperm and the egg together.
Okay.
We take about 2 weeks.
No, spelling out the stages based on what? What are the factors that determine the timelines that you prescribe or that you follow?
So depending on what the patient needs to do. So generally speaking, some people will just need counseling and that's it. Some people will need a form of treatment that is called intrauterine insemination based on the result of their tests. Intrauterine insemination. Okay. Some people need what we call in vitro fertilization.
Okay.
Some people need what we call intracytoplasmic sperm injection. ICSI. So based on the result of the test, we can say 1, 2, 3, 4, 5. This is what this person needs. This is most appropriate. And then we induce them into that. They have a discussion. We call it a treatment discussion. Okay. This treatment we're recommending, this is what it entails. You can ask me your questions now. These are my chances that will succeed. These are chances it will work. These are the potential complications that are possible. And this is the many we've had in the last 1,000 cases.
Okay.
You understand?
So they know their chance.
Exactly.
Okay.
Before they go into it. And if you're not comfortable with this, can we do this?
Okay.
Okay. This is how much this will cost. So we have that discussion before they even go, before they make a commitment.
Before they begin commitment.
Yes.
So you lay down the options, and then once there's a commitment to a particular option,
yes,
you spread out the timeline.
That's right.
Based on what? Is it their body system or their ovulation cycle?
Oh, definitely work with their body system.
Okay.
Work with their body system. As I tell people, it is assisted conception.
Assisted conception.
We're assisting what is there. We can't create it. Yes. So we still work with the woman's hormonal cycles, and then we latch into that to do the test and the evaluations we have to do.
Then you said there are 4
At least 4 different interventions.
Okay.
Yes.
And you mentioned 3 now.
Yes. Well, for all that I've described, for a patient doing an IVF, there are 4 stages. Stage 1, the woman is put on medication to make her to produce multiple eggs. This takes about 12 to 14 days. That's stage 1.
12 to 14 days.
Yes. Stage 2, the eggs are collected. The egg collection is a 10-minute procedure. Okay, so we collect the eggs. The same day we collect the eggs, our partner gives us a sperm sample, and then we fertilize the
same day.
The same day. So stage 2
because the sperm has a lifespan.
Exactly. So stage 2 is egg collection. Stage 3 is fertilization. Okay, so egg collection takes about 10-15 minutes. Then we put the sperm and eggs together, and then we now incubate it in an incubator for about 5 days. Okay, so the last stage is when we have the embryo. We now select the embryos. How are they doing? Oh, they're doing fine. Okay, the best quality embryos are called blastocysts. We now select 2 of the blastocysts and return it back into the womb, which will be the last stage. So stage 1 is stimulation to produce eggs. Stage 2 is egg collection. Stage 3 is fertilization of the sperm and egg. And stage 4 is when we return the embryos back into the womb. And then we now have a 2 weeks that we have to wait to know. These embryos are put in the womb. Are they attached? Or are they not attached? And then we have the 2 weeks.
That's very important.
Yes.
So after 2 weeks, you reevaluate.
After 2 weeks, now do a pregnancy test. Because the pregnancy test will help us know as the embryo is implanted. If it's positive, fantastic. If it's negative, then we have to see that what happened here. Why did it work? We now review all of that. We review the laboratory process, the theater process, we review the human history. We can say that we think this is what the problem is, and we think this is what we can do to help.
To help.
Yes. So we can review that cycle and can have another shot at it.
So that means you repeat the process again.
Many times, yes. But at times you have a patient that has some leftover embryos. Maybe she had 8 embryos that were top quality. We've put 2 inside. She still has 6.
That has been frozen.
That has been frozen, exactly. So she can come for that process without going through the 4 process I spoke about. No stimulation, no egg collection, no fertilization, just embryo transfer.
Okay.
So we thaw the embryos, we take out the best 2 and put back.
And that will be at no cost.
And that's at about 1/3 of the cost.
Okay.
Yes.
So for every new process, there is some payment.
Yes.
It's just that it will be reduced.
Exactly.
To some degree.
Exactly.
Okay.
Exactly.
So after that,
we go through the 2 weeks period again. Pregnancy tests, positive, fantastic. Negative, then we repeat that. But by the time someone is having 4 treatments and it's not working, we know there is something we're not able to tell. Remember I said earlier, at times you have the immune system that is rejecting embryos. Exactly. So that calls for more extensive tests. These tests are as expensive as IVF cycles themselves. So that's why we're not in a hurry to rush into them. We want to be convinced that this person, there's a problem here. So there's a problem here. These tests are usually done abroad. So we take a sample, we have biological couriers, to the biological courier, it goes to the US, it goes to the UK, other parts of Europe. They can do an analysis, they can say, oh, this is the problem here. And then we can correct that problem and solve it. For some people, they don't want to do that. They want to look at the surrogacy option, okay? So they can explore that. Or they want to look at the adoption option, and they can explore that.
Is surrogacy option present in Nigeria now?
Oh, yes, it is.
And it's easily accessible?
It's not easily accessible, yes, because the Nigerian law still tells us that the one that delivers the baby is the mother of the baby.
Okay.
So if she says she's not releasing that baby, there's nothing you can do, no matter the legal things you've signed. But some centers still offer it. They need to put proper structures in place so that
because the laws do not cover it.
Exactly, they're not properly protected.
Okay. But what about these contracts that we hear that people sign?
And these contracts are as good as people abide by them.
So you only rely on the integrity of the surrogate. So in that case, it might be safe for the client to bring the surrogate.
Yes, but you know that also has a downside.
Okay.
The downside is I can come knocking my house 10 years later.
Because he knows.
Do you understand that? So we have all that sides to it.
It's a push and pull kind of. It's a line that you have to walk.
Yes. So more often than not, what people do is that the surrogate doesn't meet the commissioning parents.
Okay.
Okay. There's a middleman. Okay. Number one. Number two. Many times the surrogate tends to stay with that middle person for the time of the pregnancy.
Okay.
Number two. Number three. Once that baby is delivered, the surrogate doesn't even get to breastfeed, doesn't even get to handle. Baby comes out, hand it to commissioning patients, and that's it.
When they're paying their money.
Yes, so that bonding doesn't happen, and then the surrogate doesn't have a rethink.
What about the sperm donors?
Yes.
And those who donate their ovary as well?
Yes. So for them, more often than not, we do anonymous donors.
Okay.
So the sperm donor has signed something that I'm giving this free will. I'm giving it anonymously. I'm not making any demands on anybody. The person that is receiving it is signing that also. So what we also know, even in a standard place, information is on a need-to-know basis. So the doctor doesn't even know who donated for who. Very few people know. The laboratory person doesn't know, the patient doesn't know, the donor just knows the gametes. Okay.
And the profile.
Exactly. So information is on that level.
The height, the among some other.
You understand that? So very few people knows who did what for who.
So it's largely anonymous.
Yes.
Largely anonymous.
Yes.
We've heard of people freezing their embryo, freezing their ovary until later than when they are ready. Is that also in practice in Nigeria now?
Oh yes, it is.
And on the African continent?
It is in practice.
And what's the success rate?
Generally,
I can freeze my ovary. Maybe I'm 20 years old and I want to pursue my career for the next 10, 15 years.
So generally, we've had very good success with freezing of sperms, freezing of embryos, but freezing of eggs is relatively new. The technology is not so advanced, so the results are not so good. So freezing of sperms, we're talking about 70%, recovery rate. But with eggs, freezing of embryos and freezing of sperms, we're talking about 70% recovery rate.
After how many years?
After, well, what we say in Nigeria, 5 years is the limit. Okay, some people, depending on when they need it, they may come in after 2 years, after 3 years.
In another climb, it could go for as many, for how many?
25 years. But for now in Nigeria, we're saying don't keep the embryos for more than 5 years.
More than 5 years, that's safe.
Yes.
But for the ovary?
Okay, so the technology of egg freezing in the ovary, egg freezing in Nigeria is slowly coming into place. And as you rightly said, it's for people that, okay, maybe I'm 28 years old, I'm 30 years old, I don't have a partner yet, I want to get involved in my business, in my career. I'll probably not be free till I'm 35, till I'm 37. But I want to preserve the quality of my eggs. So that can happen. We have a few people coming in to preserve that. It can happen. As I said, the technology is not so well developed. So
well developed yet.
Yet, exactly. Such that, as I said, 10%, 70% recovery rate for sperms. But here it's still about a 20-30% recovery rate. Such that if I freeze 20 eggs, if I come back 7 years later, maybe I'll have like 5-6 recovery surviving the thawing freezing process. As opposed to sperms in which as high as 70% of the sperms still survive that process. Yes.
All right. That's fair enough. I mean, because it's better than nothing.
Well, yes, I agree.
So, what are the do's and don'ts? That you advise patients on, or that you take cognizance of as practitioners when somebody's undergoing artificial conception treatment? Pre, during, and post.
Well, stress, physical stress, emotional stress. Because you see, stress is not just a physical thing, it's also a hormonal thing. Okay, so I'll give you a good example. A guy is stressed, then he has an erectile dysfunction. A woman is stressed, she has a low libido. Okay, because you see, stress translates to other things in the body. It triggers some other hormones, so they have to avoid that as much as they can. Okay, we have to avoid that. Then we say live healthy. Take a lot of water, take a lot of vegetables, take fruits.
Organic food.
Yes, avoid smoking, avoid alcohol. Limit coffee to not more than 2 cups per day.
Oh, really?
Cut down on exercise. So this
cut down
exercise.
On exercise.
Yes, especially for the woman. Yes, cut down on exercise.
Okay.
Yes, of course. Once embryos are transferred, to do a pregnancy test, no exercise, none at all. Yes. The critical period is the first 48 hours. Stay in bed most of the time. After 48 hours, you can go back to most of your daily activities.
Really?
Yes.
After 48 hours?
Yes.
Not even 2 weeks?
No, after 48 hours.
But even at that, you still need to be careful.
Exactly. Still have to avoid the physical stress and the emotional stress.
And the emotional stress. What about the do's?
The do's. So the things I've said: take my medications, take a lot of water, take a lot of fruits, take vegetables. Basically, those are the do's.